Dr. DiBiase, Dr. Hirao, ladies and gentlemen, it's my real pleasure and honor to present on behalf of the Fire and Ice investigators this analysis of healthcare costs and clinical outcome based on patient demographics. Now, first of all, I would like to thank Dr. Kim and Dr. Oh for allowing us to present these data at this late breaker here at the APHRS 2016 meeting. Now, these are my disclosures. Now, when we started the Fire and Ice trial around 2007, started to design the trial, at this point in time, we were working HRS, APHRS, and ERA at a consensus paper on catheter ablation of atrial fibrillation. And in this consensus paper, cryoballoon technology, or balloon technology in general, did not play a major role because most of the data which were available in these days were based on radiofrequency data. So this was changed a little bit in 2012, and the next paper was coming out, but still radiofrequency ablation was the golden standard for catheter ablation of atrial fibrillation. Now, next year, the 2017 consensus conference will be published, but most recently in 2016, at the European Congress of Cardiology, the ESC guidelines for the management of atrial fibrillation, developed in collaboration with the ACTS Society, were published. And in agreement with previous reports, catheter ablation by pulmonary vein isolation is considered to be the first-line therapy for atrial fibrillation. However, for the very first time in any guideline, position paper, or consensus paper, it was stated that cryoenergy and radiofrequency current are both effective for isolation of the pulmonary veins. Now, the Fire and Ice trial, ladies and gentlemen, was first published in the New England Journal at the same time of the presentation at the late breaker at the ACC meeting this year in Chicago. And it's the largest head-to-head multi-center randomized non-inferiority trial comparing cryoballoon and radiofrequency current. We randomized 376 patients to radiofrequency and 374 to cryoballoon ablation in patients with symptomatic paroxysmal atrial fibrillation. It was a direct comparison of point-to-point ablation using radiofrequency current, using the Biosense-Webster technology with a single-shot device by Medtronic, the cryoballoon. Now, the primary analysis of the Fire and Ice trial showed non-inferiority for efficacy, but also for safety, using the efficacy endpoint as described here, with atrial fibrillation or atrial tachycardia recurrences lasting more than 30 seconds, or prescription of antiarrhythmic drugs or repeat ablation. And as you can see, the recurrence rate was similar in the cryoballoon, but also in the radiofrequency arm. However, when the secondary analysis was performed and published, it turned out that cryoballoon-treated patients had significantly fewer cardiovascular rehospitalizations, repeat ablations, all-cause rehospitalizations, and cardioversions. Now, the question always comes up, of course, at this point in time: how is it possible to have non-inferior primary efficacy endpoints but different secondary endpoints, such as re-interventions and re-hospitalizations, as shown in the Fire and Ice trial? Now, I would like to remind everybody that the primary endpoint, the efficacy endpoint of the trial, first of all, was a composite endpoint. It is a scientific endpoint, and one failure, which means one recurrence of an arrhythmia or the introduction of an antiarrhythmic drug, determines this endpoint. Now, in contrast, the secondary endpoints, such as rehospitalization or re-interventions, are, of course, obtained and assessed throughout the entire trial. So we believe that these endpoints much better reflect the atrial fibrillation burden over the period of study as compared to the primary endpoint. Now, in this analysis today, we would like to address two different studies that we have performed based on the trial data of the Fire and Ice trial. First of all, we are comparing the impact of the cryoballoon and radiofrequency ablation on the payer costs associated with healthcare utilizations throughout the entire study. And secondly, we would like to determine the impact on 3 different national healthcare systems based on these data. The second study that we have performed is to evaluate the patient demographics which are associated with the primary outcome and the secondary endpoint cardiovascular rehospitalization from the cryoballoon and radiofrequency ablation cohort to determine which patient responds favorably to atrial fibrillation in general, independent of the catheter group, and secondly, to see whether there are any treatment differences between both ablation strategies. Now, in our first analysis, ladies and gentlemen, the health economic analysis, we examined the data from a payer perspective. The methods of analysis were as follows. First of all, we have collected all healthcare utilization data throughout the entire trial, which represents the event rate inside of the trial. The total healthcare costs were then calculated by multiplying the trial collected healthcare utilizations by standard units costs, and the analysis, as mentioned before, was performed for the 3 different healthcare systems: Germany, the UK, and the United States. Furthermore, procedure codes were retrospectively assigned to each healthcare utilization, with the coder being blinded to the therapy, but with full access to the study HCU data. And finally, these codes were mapped through country-specific diagnosis-related groups, so-called DRGs, which determined the payer costs. In our second study, we examined baseline patient characteristics to analyze potential predictors of outcome. The methods for analysis were: first, we examined patient demographics by univariate analysis against the outcome data, primary efficacy, and cardiovascular rehospitalization for the entire patient cohort across 23 baseline patient demographics. Then we examined a subgroup, which means based on the different catheters used in the trial, responses, and used multivariate statistics to determine if there were any interactions with primary efficacy or cardiovascular rehospitalizations. Now let's have a look to the results of the health economic analysis. Now this slide describes the total number of healthcare utilizations throughout the study, divided in the cryoballoon group and the radiofrequency group for all cardiovascular related events and for non-cardiovascular events requiring hospitalization. Now, as you can easily appreciate, these numbers were mainly driven by differences in repeat ablations between both technologies, atrial fibrillation rehospitalizations, and cardioversions. The difference between non-cardiovascular hospitalizations and hospitalizations for non-atrial fibrillation were not very prominent. We then ascribed a healthcare utilization payment to each of these events. As you can see in this slide, the top events are listed here. And as you can see, these DRGs do different, with the highest payment in the United States, the lowest payment in the UK, and Germany is in between these two countries. Now, after multiplying the healthcare utilization by the cost of the healthcare payment, we were able to determine the total costs used and the cost differentials, which are shown here in red, between catheters by 3 national healthcare systems. The cryoablation group, ladies and gentlemen, always demonstrated a significant cost reduction difference compared to radiofrequency in all 3 healthcare systems. Now, the largest cost reduction, as shown in dark blue, was for repeat ablations, and in light blue for cardiovascular hospitalizations across all 3 countries. Now, the same data from the previous slide are shown here, presented as the total differences per patient. At the individual patient level, there was a reduction in patient-level healthcare costs across all cardiovascular and total costs, as you can see in this slide. And again, the difference were the highest in the United States, followed by Germany, and finally by the UK. Now let's move to the second analysis, which is addressing predictors of outcome. By standard statistical practice, we have examined 23 patient baseline variables in univariate analysis against the primary endpoint and against cardiovascular rehospitalizations. Now, in the study, we have collected even more baseline variables, but for the sake of this presentation, I limit myself to these 23 parameters. Now, in this slide, the significant univariate analysis interactions are shown. This analysis is inclusive, again, I would like to mention, of all patients without subgrouping by the ablation modality. By univariate and multivariate analysis, both gender and baseline direct cardioversion were independent predictors of the primary endpoint, with a lower number of recurrences in the male patient population and in patients without a history of direct cardioversion. In addition, by univariate and multivariate analysis, also for the secondary endpoint of cardiovascular rehospitalization, there was gender and, in this case, hypertension, an independent predictor of cardiovascular rehospitalization, with less patients, the male patient population, being admitted to the hospital, and with patients without a history of hypertension. Now, when examining by subgroup analysis, which is shown here, we found that there was no difference between the ablation modalities, which is either cryoballoon or radiofrequency, with regard to the primary efficacy endpoint, which is in agreement with the data that we have published previously in the New England Journal. However, there were significant multivariant interactions when examining cardiovascular rehospitalizations by catheter groups. These differences were statistically significant for patients with CHA2DS2-VASc 1 to 0, 0 to 1, and prior direct cardioversions. Now, regardless of whether patients had a baseline history, here we go, I think. Okay. Let me start here. This is the test for the CHA2DS2-VASc score, and as you can see, For the CHAS-VAS score, when we looked into this multivariate interactions, there was a difference, a significant difference in favor of cryoballoon treatment in patients with a CHAS-VAS score of 0 to 1. However, this difference could not be demonstrated in patients with a CHAS-VAS score 2 to 5. Now, when we did this subgroup interaction test for patients with a previous history of cardioversion or no cardioversion, we found that independent from the history of cardioversion, of no cardioversion, there was a favorable outcome of patient undergoing cryoablation in blue versus radiofrequency ablation with a test which was highly significant for those that had a history of previous cardioversion, as shown by these dotted lines. So in conclusion, Mr. Chairman, ladies and gentlemen, the health economic analysis of the Fire and Ice trial shows that the payer costs for cryoballoon ablation were significantly lower than the costs for radiofrequency ablation, and these costs were driven by differences in repeat ablations and cardiovascular rehospitalizations. The savings persisted across the 3 healthcare systems analyzed in the study. Predictors of outcome, the female gender, and the baseline history of direct cardioversions were independently associated with increased primary endpoint rates. Female gender and hypertension were independently associated with increased cardiovascular rehospitalization rates, and the cryoballoon ablation was associated with significantly less rehospitalizations for cardiovascular reasons in patients with a baseline history of direct cardioversions and or patients with a baseline CHAS-VAS score of 0 to 1. So this is the list of committee members, and I would like to thank everybody, the steering committee members, the review committee members, and the safety board members, as well as all the investigators for all the contributions that everybody made for the success of the trial. Thank you very much for your attention.
Thank you very much, Professor Cook, for this very well presented and strong data from the Fire and Ice trial. Are there any questions from the floor? If not, in the meantime, I have just a couple of questions. So the first one, you said that the primary endpoint was freedom from arrhythmia after the blanking period, 90 days, with or without antiarrhythmic drugs. So my question about rehospitalization is, these were counted in the blanking period or after these 90 days that was the primary endpoint of the study, and how many of these patients in both groups were on antiarrhythmic and how many were not?
Now again, the study, first of all, the study has a combined endpoint. It's not only recurrences of atrial fibrillation, it's also, and in addition, whatever came first, the initiation of antiarrhythmic drug treatment or reablation. Okay. So whatever came first was counting as the primary endpoint. Now, for the primary endpoint, of course, only data outside of the blanking period did count. Now, for the secondary endpoints, all the data did count. Also for the healthcare utilization data, all the data did count, because, of course, we strongly believe that from a patient perspective, it doesn't matter for the patient whether he has to have a redo procedure inside of the blanking period or outside of the blanking period. And of course, the same is true for the healthcare system. It doesn't matter for the healthcare system whether the patient is done inside or outside of the blanking period. So that's why we strongly believe that the secondary analysis, which is looking to atrial fibrillation burden, and again, it's a randomized trial. We are comparing two technologies within the same patient population. And as we have shown, the patient population is not different between the two groups that have been treated. So the differences that we found for the secondary analysis were not separated within and outside of the blanking period. And again, since we did not measure directly atrial fibrillation burden by implantable loop recorders, for instance, we believe that recurrences of atrial fibrillation, or the first recurrence of atrial fibrillation, is a good primary endpoint, but it doesn't tell the whole story. for patients that are suffering from atrial fibrillation, whether they profit or do not profit from an intervention such as ablation procedures. So we strongly believe that besides the primary endpoint, the secondary endpoints are extremely important in such a trial. And interestingly enough, it showed that the benefit is on the cryo side for all the secondary endpoints which were predefined. And it also shows that there is no single subgroup in favor of radiofrequency ablation, but there are a couple of subgroups in favor of cryoablation. In particular, as mentioned before, it's the gender. Male patients profit, as we know, profit more from catheter ablation than females. And the same is true for hypertension. Patients without hypertension have more profit than patients with hypertension, which is also not surprising.
I agree with what you said. The only issue I have is that probably, we use this blanking period and we say we need to wait to do a second procedure, a second intervention during the 90 days. So I agree with you that on the patient perspective, rehospitalization, shock, and this calculation have an extreme important aspect from day one after procedure. But for re-intervention, there have been debate during the years in the literature, should we do the second procedure during the blanking period, after the blanking period? So, I think that part of the analysis, we are now suggesting in general, don't do second procedure before in the blanking period.
Yeah.
So
but I also agree with you here, but the issue is we did not encourage
of course
anyone to do a second procedure within the blanking period. But as we all know, there are patients, of course, that are highly symptomatic. Some of these patients do even worse after the first ablation procedure than before. So the patients come back and you may start an antiarrhythmic, but the patient doesn't do better. And so at the end of the day, it's a clinical decision, and we cannot withhold the clinical decision just for the sake of a randomized clinical trial. So, and we want to reflect clinical practice. So I truly believe this blanking period, which is debatable. What is the right time of the blanking period? I think no one knows it. But if we agreed in the trial between the investigators to define it as 3 months, but of course we have to allow physicians to treat patients if they are highly symptomatic within the blanking period, even if this is not what we would like to see from a research perspective. I agree with that.
And the second one was, we knew this from the literature, which was mainly driven by radiofrequency energy, that males respond better than females. So it's nice when you can see a reproduction of previously reported data. So the question I have,
let me just make a comment here before you ask your question. I mean, the Fire and Ice trial is the first ablation trial, probably the first interventional trial, that had a 40% female inclusion rate. Okay. So the data are really valid, because in most of the studies, the females are underrepresented, mostly only 20%. So I think that really is an important set of data here, that females are not doing as well for the secondary endpoints as males, which I believe is something that is really valid based on the Fire and Ice data, because of the high representation of females in the trial.
This is why my question, because we reported that some females, even with paroxysmal atrial fibrillation, do not respond to that because of non-PV trigger issues. So do you believe, or do you have data that redo procedures improve the success rate in this female, or they still fail, as I believe, because they have a non-PV trigger rate of fibrillation?
Actually, we had a discussion yesterday within the investigator group that we are looking now closely into the redo procedures. So this data have not yet been analyzed, but I fully agree with you. We need to analyze them carefully. We need to know how many patients did have gaps that had a redo procedure, what was done during the redo procedure, and finally what was the outcome. These were not data that were primarily collected for the study, but of course we will have a retrospective analysis on these data to answer what I also believe is very important information.